Welcome to Life Happens, where Texans come to protect their legacy and prepare for the second half of life. Join your host, Attorney Kim Hegwood with Hegwood Law Group, and our weekly guest as we navigate the challenges that emerge as life happens. Now here's your host, Kim Hegwood.
Hi, and welcome to the podcast. I'd like to introduce Laurie Cantrell with Amed Home Health, and welcome to the podcast, Laurie.
Good morning. Thank you for having me.
And so we'll really appreciate you coming on. And the goal always, in what we do is educating, seniors, really making sure that we can give them as much information as possible. And the pandemic has really changed things, hasn't it?
Absolutely, it has. There have been we have seen tremendous changes over the last several months. We're seeing delays in seniors getting care. So when they are getting care, they're getting much sicker, or they're being diagnosed, they're much sicker at that point. There's quick turnaround going in and out of the hospital. So patients are coming home from the hospital much sicker. They're oftentimes avoiding other levels of care that they would have normally obtained, such as skilled nursing or inpatient rehab. So we're seeing patients come home much sicker and needing a lot more care in the home.
And do you think that's because of COVID specifically? Is that the reason that people are coming home not in good shape and requiring a lot more home health care?
I think we've definitely seen a change because of COVID. I've had, for example, a patient with a fractured hip that went to the emergency room, was sent home the same day and told to return when COVID was over. Taught the family how to keep the patient just mobile enough so that hip did not set. I know that sounds unbelievable, but that is a true story.
It sounds horrible.
It is. It's scary, and that's not to criticize our healthcare system. The initial wave of COVID back in late March and early April, I think everybody was flying by the seat of their pants, literally. The facilities they were told to not have anybody that basically wasn't COVID. They were expecting this huge onslaught of patients to hit. And I think that's balanced a little bit now.
Yeah. So let's talk about the different types of care that's available now. So if you've got a loved one that's sick and you may not want them to be in a facility, what's available out there now for our listeners so they know what to do, or at least have some options when it comes to their family?
Sure. So home health care was designed to be kind of that bridge from an inpatient stay to home. Historically, people stayed on home health probably longer than they were supposed to or even needed to, and Medicare made some changes that went into effect this year to help stop some of that. But because of COVID, we've seen a little bit of a reversal of that. If somebody, say, breaks a hip or has pneumonia or needs cardiac surgery or something, based on their level of functioning and the care they needed when they leave the hospital, their options still are to go to a skilled nursing facility, which is located within a nursing home, or to an acute rehab, which is usually freestanding. Some are within the walls of a hospital, or go directly home. And what we're seeing right now is people bypassing those first two options because they're scared of COVID, or one of the other reasons is they won't be able to see their family. And there are regulations in place right now that are prohibiting any visitors in these types of facilities. And until the governor or the federal changes are made, that is still the case. So if you have a family member that, even on hospice, it's very sad right now. If somebody is on hospice and they're in a nursing facility, family can't be with them until they are literally actively dying. and then they're allowed to come in just at the very, very end. And sometimes the patient's not even aware at that point. So
I think that's probably the most devastating thing that I've seen when it came to COVID.
absolutely, it breaks my heart every day.
The isolation, the fact that, our seniors, family members can't be with the people that are, as they're dying, they can't be with them.
Mm-hmm.
For me, that's just devastating. I mean, I couldn't imagine. I mean, I was with both of my grandparents when they passed, and with my grandmother, the whole family was there, when she passed, like the week before. So everybody got to be there with her. Now she didn't know we were there for the most part, I don't think, but we got to be there and say our goodbyes and things like that. And I've had a lot of clients that have called the office and said, you got to get me in. What can we do? And then we've talked to clients a lot to maybe need to pull them out, bring them home, close to the end. Maybe that's an option that you may want to consider. And I'll tell you a story. My sister called me and she says, I read an article where they wouldn't let this woman visit her husband in the nursing home. So she got a job as a dishwasher.
Yes, I saw
I mean, it's one of those things where, can you imagine being in your 80s or something, washing dishes so that you can spend time with your family? I mean, it's just that, to me, that was sad. And,
I think there's some tough choices that people have to make right now. And I've had some conversations with my own in-laws who are in their 80s. And, we're seeing a lot of depression that's been on the news, and it's to be expected. And that's not just in the elderly population, that's across the board. But my in-laws have not allowed anybody in their house or been in anyone else's house since this started back in March. And they're not going to church. They're doing virtual church, but they were very active people. And, at some point you have to ask and do kind of a benefit analysis of, is this the right scenario? I'd rather be with loved ones for a month than be isolated for 6 more months of life, maybe. Yeah. So, home health can offer that option. It's really important for families to understand that we are not a substitute for the custodial care part of a patient's needs or a loved one's needs. Custodial care refers to those things that we have to do on a daily basis: bathing and dressing and meal preparation, eating, even taking our medications, getting dressed, changing linens, housekeeping, shopping. Those are all activities of daily living. That is not a medical condition. So a lot of people misunderstand that their Medicare or other insurance benefits cover those needs, and it does not. So, but within home health, we can provide therapy in the home. It will not be as much as you can get going to an acute rehab. I think it's a very individual decision based on the caregiver availability, the ability of the patient to live or the person to live in the home that they have, whether there's other members there, a spouse or adult children living there, their ability to afford or qualify for other forms of custodial caregiving services that, while they might qualify, may not actually even be available because of COVID. There is a shortage of caregivers sometimes, and for some agencies, not for all. But nursing can come into the home and help. For instance, IV antibiotics, that's something that seems to still be a lot of misunderstanding. That is something that can be very easily done in the home if there's a trainable caregiver available, even if that's a daughter or son that drops by once a day to hook it up, or twice a day if it's ordered that way. So you can avoid.
I'm not so sure I'd want to be the one that had to insert the needle.
You don't have to do that. That needle is inserted permanently, and it's called a PICC line, and you're just hooking up 2 little plastic components to infuse at that time. So we actually, as nurses, come out, I'm not a nurse, I am a social worker. Our nurses come out and teach the patient and supervise it and reinforce the teaching and are there for emergencies. with it and change the dressing and check the line. And then when the antibiotics are over, that line is pulled.
Oh, good.
So there's options, and Medicare made some changes. Actually, CMS did, as the nurse for Medicaid and Medicaid, Medicare and Medicaid, did loosen some of the requirements around home health during COVID.
Yeah. How has your company seen healthcare change for seniors during the pandemic?
Well, again, Medicare did immediately when this happened, change some of the rules immediately. So there's always been a requirement of a face-to-face evaluation to be done either 90 days prior or within 30 days after the initiation of services. That can be done virtually. It always had to be done by a physician. Are signed off on by a physician, and Medicare has now expanded that, and I understand this will be permanent to allow nurse practitioners and physician assistants to actually sign those documents going forward, which is huge. And they now, homebound status has always been a criteria of receiving home health, and being homebound was defined as needing assistance to leave the home. You couldn't do it frequently or easily. You needed another person or you needed equipment to leave the home. And Medicare made risk of exposure to COVID one of those criteria. So if you have a parent who's in the high risk category, being over the age of 65, and they have that in and of itself is a risk factor. So it's a lot easier to qualify during this time.
I would imagine that makes families feel a lot better, knowing that they can lessen the risk for their loved ones by having home health come in versus getting them out of the house and things like that.
Absolutely. I had a case very recently. The mother was having to go every week to have labs drawn. She was receiving cancer treatment. And getting her out, she was very weak, getting her into the car, taking her to the lab to have that drawn was exhausting, but also very risky for her, very risky. So the husband had come on service after having to have an emergency orthopedic procedure. And the daughter was like, "Can you help my mom?" And we're like, "Of course we can." So just drawing labs is not a skill, but the mother had lots of other issues going on that we were able to help address. So we prevented her from having to make that trip every week. So I think that's a great example. I have another one of a gentleman who had chronic urinary tract infections, and he had become symptomatic and was actually urinating blood. And he called us and he was, "I don't want to go to the hospital because I know they're going to put me in and I'll never come back out." That's what he felt. We were actually able to do the right thing with the doctor, get the proper orders, get out there, get the urine, get it to the lab, find out, yes, he had it, and get him started on the proper medication and follow up with him. And we kept him out of the hospital for 2 additional months.
Well, that's fantastic, because no one wants to go to the hospital
right now, right?
They want to go right now, but you don't want to go anyway. So, what I'm finding is that even though, COVID has made things, very problematic, I think what we're going to find is there's going to be some good changes moving forward, that's going to come out of it. And so, just having, a physician assistant or nurse practitioner be able to sign off on things rather than having to find the doctor to do it. That makes it easier. It saves Medicare some money. And so, because I know they're all about saving money.
Absolutely.
But I think that the more you can give someone care with the least amount of stress on them, keeps them healthier longer and lessens their medical cost. Do you see that being any kind of correlation?
That's kind of a brilliant statement there. Maybe you should go run CMS. I know. Imagine that. I just what has happened with virtual medicine, and even for myself, I have to say, I'm not super tech savvy, but I've had to do virtual visits as well. And wow, it's just so convenient. And it makes it's so much less expensive, I think, for everybody involved. And it's not a substitute for when you need hands on, but it's a great adjunct, and I think it will increase access. When the number one causes of readmission to the hospital is not accessing primary care for the senior population. And this has taught us, I think, a very new way of addressing that. So I hope we see physicians and patients want to continue forward with that. It will help, I do think, improve and reduce stress, like you said. Transportation issues that are a problem. It's painful for some patients to get out of their home, physically painful, and get in the car and go. And not everybody has a son or daughter that can take off work. And
we found a website, I think it's one of Uber's, the gogograndparents.com. You can get on and have a car pick up your parent or grandparent and take them where they need to be, and then get that same car or a different car to pick them up from there and take them back home. And you just go to the website to to start that process, or just like we would normally on our app find an Uber. The website does it so you can do it for someone else. So I haven't tried it yet, but
that's brilliant. Yes,
I've heard really good things about it. And so, because a lot of times, I was so fortunate that I had my own law practice when my grandparents were declining, because I dictated my own schedule. So I worked around the doctor visits. I worked around buying groceries. I worked around a lot of those things that made it easier for me.
Right.
But you see a lot of people don't have the luxury of, they work for someone else. It makes it a lot more difficult. So I appreciate it. And I think I saw something that came through my email from my insurance company talking about doing more telemed, and hey, this is available. We want you to use it. And I'm kind of old school though. I want to go see my doctor. And so, I'm like, I want him to look at me. I mean, really,
right. Well, again, it's not going to be a substitute for all the hands-on that's needed, but I think there's times my daughter developed or came down with strep last month, and it's amazing. Cameras on the computer could clearly show the spots on her throat. Now, we still had to get COVID tested and strep tested at a drive-through lab, which was very convenient with our physician group that we use. But it was kind of nice. She was running a fever and she felt horrendous, and it was nice not to have to go sit in a waiting room. And now she's an adult now. She's 20, but still mom. I'm talking about her like she's 10, but
that's okay. They're always going to be our babies.
Oh, they are. They are.
So, most definitely.
Without a doubt. But I think, there's options for patients right now outside of avoiding seeking proper health care. And home health it's pretty easy to get. There's certain criteria, again, that have to be met in terms of there being a skill that we're performing. We have to be there for a particular reason. But
give our listeners some examples of that. Maybe because they don't know what kinds of things maybe they may not even be thinking about. These are some options that I can get home health to come in for.
Right. I'll give you a couple of just really recent cases that we've had that are coming from the community to the home. So exacerbations of infections where the doctor can order the labs without, normally those patients would have been sent to the ER, they would have been admitted to the hospital, they would have stayed 2 or 3 days, and IV antibiotics would have been set up and the PICC line inserted, patient sent home. This is an actual friend of mine. Her mother had a severe UTI, didn't respond to oral antibiotics. They did exactly that. They did the lab work, got it tested. She went to an outpatient place to get her line inserted, and everything was done without her ever having to walk into the hospital. And she's now on IV antibiotics for 3 weeks. And our nurses went out the first couple of days, train the family how to do it, and we go out and change the line every week or the dressing. And if they have a problem, they call us, we go out. I have another patient who's having rapid weight loss. The daughter's extremely concerned she's not taking her medication properly. She's had some change in mental status, and she has some medical conditions that could be contributing. Maybe it's isolation and depression starting. We can come in and do some medication teaching, and be another set of eyes that are identifying. We won't be able to stay long in the scenario, but we can help assess and determine. And it may be that this patient or this person can no longer be alone. That may be the outcome of this. But it may also be that we figure out that there's confusion going on from X, Y, and Z that we can help resolve. So,
well, it really sounds like, and I'm pretty sure listeners would probably feel the same way, that that home health care has come a long way to help keeping people home and safe these days, as far as, providing a lot of the necessary medical, testing and things like that you would have had to go to the hospital for, that they're now able to do at home.
We can actually you can get x-rays in the home, ultrasound in the home. There's a lot of services that can come to the home right now. Even swallow studies for patients who may be choking, they've had strokes in the past, or Parkinson patients. There's a lot of services that can come to the home. I want to point out real quickly, though, that I gave you 2 examples of patients who could avoid going to the hospital, but we are definitely seeing profoundly sick patients at home. And I do mean, they're calling home health right now. There's been some articles written and published recently. Are we the new skilled nursing facility? Are we the new inpatient rehab? Are we the new hospital? I actually read an article yesterday that talked about providing hospital level care in the home. And there's a trial going on where the hospital is sending staff into the home. So on certain types of patients. So instead of bringing them in, they're doing it at home, which is completely different than home health. But we are able to take very complex wounds and teach patients about their heart failure. So patients that maybe, again, because of isolation, they've developed some altered mental status. Depression can cause that. Poor diet can cause that. Change in the overall environment can cause changes in mental status. And sometimes us being there can help figure that out. So it's a variety of scenarios.
Yeah, we see clients in the office sometimes, and they're worried that their parents are declining mentally because of, they've seen them and they're starting to notice changes and things like that. And I always send them out to do 2 things. I said, make sure they're not dehydrated, so call the doctor, have them checked, that kind of stuff. And then UTI is another great big, reason that people's mental health status declines as well, that we see a lot in seniors. And so a lot of times they're panicking, thinking that they're getting dementia, Alzheimer's, when really it's just a medical condition that can be treated very easily. And so,
you were so spot on with that. My mother, who, and I wish I'd known you at the time, because I did need the services of an estate attorney when I went through this with my own mom. But my mother would actually become acutely psychotic with UTI. And after I moved her to Texas, I got so good at predicting them. The doctor would she goes, I'm just going to go ahead and prescribe it. But after like the 3rd one, I would always be able to predict about 2 days before a lab could show that she had bacteria in her urine, because she would have such an acute mental status change. But I actually thought the same thing. She had developed a serious dementia, and it was chronic UTIs. So their infections can change patients dramatically, or change people dramatically, or the elderly for sure.
Yeah, we talked to them about, infections, dehydration, if they've had surgery, anesthesia. It takes a while to come out of the fog, so little things like that. And so it sounds like that Medicare has really improved, the access to medical care these days, which is, easier. I do like, thinking that, hey, I can get my hospital type care. I mean, I know that's a little more than you are doing right now, but just think about the possibilities for your agency and other ones if you're looking at what can we do more in the home, because everybody knows you always get better faster in the home than you do in the hospital. And so besides the things we talked about earlier with, the nurse practitioners and physician assistants, what else has Medicare done to improve the access to home care right now?
Um, well, I guess just hitting on those three things, the definition of homebound has been relaxed a little bit. The ability for nurse practitioners and PAs to write and sign the orders, and that's going to be ongoing. The big thing that we're still waiting on Medicare to rule on is the use of telemedicine in home health. And what we had to do, and very few agencies out there are taking COVID cases. And just for perspective, in the Harris County and greater Harris County area, there are well over 800 agencies and 1,500 if you include all their branches in the greater Houston area. So we're talking a large number of agencies. Most are not taking COVID, and a lot of them don't take complex patients. My agency is taking COVID patients on a case-by-case basis, by the way. So that is an option for recovery as well. And we do get some patients that are still actively COVID. They have not yet had a negative test, but they are not sick enough to have to stay in the hospital. They're still very sick, but they are able to come home. And we saw a lot of patients trying to send them home early to make bed space for others. But the use of telemedicine for those patients has not yet happened. Medicare is not paying for that. It would be a very expensive endeavor for home health agencies to purchase the equipment to do that. We don't get reimbursed for the use of that right now. But if we have a COVID patient come home from the hospital, we will send nursing into the home. We have a COVID team, but we are not sending. We actually have a therapist now willing to go. But it's literally on a case-by-case basis because you have to have staff willing to expose themselves and risk exposing their families. So we're fortunate enough to do that. So we're all hoping that Medicare is going to approve, or CMS is going to approve the use of telemedicine. And what CMS does, most insurance companies follow with. But so yes, they've improved access. Medicare had pretty good access to begin with. The other insurance companies and the Medicare replacements there is a process to get approved, get your visits approved. But we're hoping to see that approved in the near future because that will make it also much better for patients. Be a lot easier to triage emergencies and keep them from going back to the hospital if they call at night, for instance.
Yeah, I think the better you can do preventative, the easier it is down the road to maintain better health. And so hopefully, CMS, our legislators, when they can, decide on something, can actually be, helpful in the sense of, kind of pushing for those things moving forward. That's really, really helpful. And so
I do want to also praise CMS though, with the stimulus package that was pushed through, there was a lot of additional money put into healthcare to protect the seniors, and money that was sent to the agencies for home health. And I can't speak to everything else, but to other entities in the healthcare arena as well, to help make sure that we had funds to buy PPE, that we had the ability to keep our staff working so that we could be there to take care of patients. So I do have to say, I think the government's response on that end was good. It did, it helped. It definitely helped.
Well, if the one thing I can tell you is to tell those people that are taking care of those patients with COVID, we thank them, and we thank their families, because that has to be a little traumatic on the family as well, knowing that you've got a loved one that could potentially be exposed. And
Absolutely.
so the rest of us are, like I said, eternally grateful because you're always grateful that somebody's is willing to step up and be that person. And so I really commend your agency for doing that. That's awesome.
Thank you. I will pass that on to those frontline people doing that.
Absolutely. Tell them we couldn't appreciate them more. And so, but for those listeners out there that might want to absolutely, use your services, and could you give the phone number for us?
Sure. My office number is 713-941-2115. Again, 713-941-2115. And we do have offices throughout the city. I'm in particular located up north. But I'm happy to answer any questions anytime.
And so, well, Laurie, I just want to appreciate so much you coming on the podcast today and really educating our seniors, because it's so important these days to make sure that we're doing all the right things to help them get good information. And if they can't get good information, we always want them to.
Well, thank you for helping make sure that happens. That's always been, as a social worker for 30 years in the Houston community, it's always been my goal is have good, accurate information disseminated. So Thank you.
We see a lot of clients come in the office that get a lot of bad information. Yes. So we want them to have good information. And so anyway, thank you so much. And it's been a pleasure talking with you today. And we look forward to seeing you again in the future.
Thank you. Stay healthy.
You as well.
Thanks for tuning in to this week's episode of Life Happens with Kim Hegwood. Be sure to tune in every Thursday at 10 a.m. wherever you listen to your podcast as we navigate through the challenges that emerge as life happens.